Tanzania ranks as one of the countries with the highest HIV prevalence. Between 5 to 7% of the country is HIV positive. Tanzania is comprised of 26 regions, and Mufindi District is located within Iringa region, currently the most affected region for HIV, at a 14.8% prevalence. Mufindi District as a whole has a comparable prevalence to that of the region, but in the southern half of the district, the prevalence is much higher. Between 2005 and 2009, Mdabulo Health Dispensary, located in the southern half of Mufindi District, tested nearly 3,000 patients for HIV. Of those tested for HIV during that time, 35% tested positive, and for women of reproductive age, the prevalence was 44.9%. This ubiquitous presence of HIV, together with a complete lack of treatment options in this particular part of Mufindi, led to a mass mortality of adults, leaving many children without guardianship or living with less able relatives, such as elderly grandmothers. This caused an overwhelming number of orphaned and vulnerable children in the community. A local organization called Fox's NGO, while attempting to address this problem and through the process of needs assessment strategies, realized the biggest factor in determining if a child needed special assistance or not was the vulnerability of the child, specifically how many capable relatives were alive to support the child. The problem of the overwhelming number of orphans and vulnerable children was first discovered in the early 2000s, as many youth as young as 12 and 13 began to drop out of school and ask for work so they could support their younger siblings. As more and more children started to seek work, Fox's NGO took the next step to find out what were the precursors to this problem, how large was the impact of this issue, and what could be done to help. To help assess the problem in more detail, a family history forum was designed and implemented in the 16 villages surrounding the project area. It was discovered through interviews with registered OVCs and their families that not only was vulnerability a problem, but it was at a very critical point. These forums and other gathered information led to some useful quantitative data. Around the same time, a nationwide report from the Ministry of Health and Social Welfare, which aimed at mapping all the children deemed most vulnerable, showed some alarming figures for Mufindi District, and in particular, the project area of Fox's NGO. Also, at the same time, the HIV prevalence rate from Mdabulo Health Facility, which services a population between 30 and 40,000 people in the NGO project area, was calculated to show this anomalous HIV prevalence. The rate of 35% was vastly higher than that of the district, region, or country as a whole. The number of patients receiving treatment, once available, shot up to over 2,000, which was comparable to a district or regional health center and not that of a rural health facility. Meanwhile, at the local primary schools in the area, the school boards had started recording how many of their students were considered orphans. In Tanzania, the term orphan is used to describe a child who has lost one or both parents. The average percentage at each school of students who had lost one or both parents was between 30 to 45%. Attendance rates at the schools were dismally low. Often, nearly 100 students per school per day were recorded absent. School rankings were equally as dismal, with most schools in the area ranking in the bottom third or lower. As an example, the best ranking school at the time was Igoda Primary, coming in at only 52nd out of 151 schools in 2008. As for qualitative data, interviews with school boards, village leaders, and families from the community also showed that quality of care for the children in the area was a major concern. When interviewing head teachers at the primary schools, the number one deterrent to positive development at the school was the number of children attending with no relatives to help contribute to their educational achievement. Head teachers cited this as a major obstacle to progress, explaining that students without capable parents often attended school with no resources or school supplies and rarely contributed financially to the school development. The family history forums also showed quality of caregiving in that a large number of homes in the village were of very poor quality. This was defined as thatch roof with either sun-dried bricks with mud mortar or completely mud walls. The forums also told the organization there were hundreds of households run by grandmothers whose own children had often all passed away, leaving them to care for the remaining small grandchildren. Other homes were led by children who had no living adult relatives to help support the family. At this time, there were over 200 women enrolled at the NGO's basket weaving program, where women made baskets by hand to earn income as they had become too ill to farm their fields. The program was designed to help those most in need, and so the high enrollment was another sign that the community had too few able-bodied people. Given the information, both qualitative and quantitative, it was clear that there was a problem, but due to the lack of historical data, it was not clear as to how long this problem had existed. Barring major interventions, the trajectory of welfare of children would continue to decline, and more risk factors would engulf the community, as the protective factors of social structure and familial support was beginning to disintegrate. The information gathered and needs assessment exercises conducted led the NGO to make a multifaceted, holistic approach to addressing the problem. Fox's NGO sought to prioritize the needs of the community, and they saw that the most urgent issues were related to healthcare, education, and direct orphan care. These three priorities became the fundamental branches of the organization's structure. In the early stages of the NGO's development, there was a critical problem of children who lacked even their most basic human rights due to the fact there were no existing relatives to help support them. Igoda Children's Village was established to provide comprehensive care to those children who had no family alive and nowhere else to go. This directly addressed the issue of vulnerability of children as a stopgap to the greater health status problem at hand. The fact could not be ignored that there were many children in critical need of care while the larger systemic problems were being addressed. Meanwhile, longer-term strategies were initiated to increase the number of familial supporters for the children and to strengthen the social structure of the community. One of these strategies was to improve health services available to this rural community. When the NGO started, there was no place to receive treatment for HIV. Cost of transport to the district hospital was prohibitively expensive. This discouraged even HIV testing, as people saw no reason to be tested if treatment wasn't available to them. This in turn caused a higher death rate among parents and relatives that could potentially care for the well-being of a child. The lack of healthy adult caregivers led to children carrying the burden of family responsibilities, further leading to higher rates of school absentees. The NGO implemented a strategy of bringing health services to the village. This included educated healthcare providers, such as a midwife, medical counselors for HIV, and a lab technician on the side of human capacity. In addition, equipment, building infrastructure, and medications were made available by the NGO, thereby erasing the cost of transportation completely, which increased enrollment in HIV treatment programs. At the same time, Tanzanian volunteers were trained to educate people from this area in their own homes about testing, treatment, and preventative measures, increasing the overall health of the community. The client base at the care and treatment clinic went from 200 people receiving monthly treatment to nearly 2,000 people enrolled in just under 2 years. As great strides were made in access to HIV treatment, more developments were needed to improve access to overall health services, as opportunistic infections were common in the community that contained so many immunocompromised people. Also, the sheer lack of existing health facilities and resources meant a severe service gap, which discouraged people from seeking basic health care on time. Women in labor who experienced complications, for example, are transported via taxi 50 kilometers away to the district hospital, as resources such as operating procedures do not exist in the area. The NGO has taken on its most ambitious project to address this problem by starting construction of a referral hospital that will service the 30,000 to 40,000 people in its project area. Additionally, to help reduce infant and child mortality due to malnutrition, as well as to reduce the rate of vertical transmission of HIV, the NGO implemented an infant milk formula program. This consisted of providing infant formula for babies over 6 months, as per World Health Organization guidelines for HIV-positive mothers. These mothers would join the program after connecting with a home-based care volunteer through the care and treatment clinic. The program utilized all health services available to this community by requiring the mother to attend monthly seminars on good health practices and family planning. They were also visited by the volunteers regularly to ensure proper use of milk formula, cleanliness of bottles, and water used. But also they had to attend their CTC treatment day each month and they were required to show the program directors their baby's clinic card, which, among other things, showed the baby's monthly weight and vaccination status. Another factor for the spread of HIV was the lack of resources the remote community had to educate itself against the disease. This led the NGO to take on various educational initiatives. One program was started to directly impact the learning environments of children at the primary school level, an age group which was particularly at risk for being neglected. As parents were too sick to contribute to the development of their children's schools, classrooms and libraries were added by the NGO, leading to more teachers being placed by the government and language development increasing, which furthered student successes in secondary school. As the health of the community was already dangerously poor, poverty increased, leading to lower rates of students being able to attend secondary school. Also, as the project area is located in a remote area, basic services such as electricity, piped water, and phone network are unavailable, and with overcrowded classrooms with nearly no teaching supplies, it is difficult to entice teachers to bring their services to this community. This leads to a high fail rate of secondary students, further leading to parents not wanting to spend the meager family income on the children's education when achievement is unlikely. One program initiative driven to educate the rural poor was vocational training, offered to children unable to afford school fees in the government system, as well as those having failed out of the system due to hardships at home. Finally, a feeding program was started at the primary school as a pilot program that has since been copied by other schools. Most students were unable to go home for lunch, leading to mass absenteeism and behavioral issues in the classroom due to non-attentive, hungry, and tired students. This made the feeding program a particularly important educational strategy, as it provided a nutritious cup of porridge to all of the students at the primary school each day, increasing the attendance from 82% to 97%. The national exam results also increased from 52nd in 2008 to 7th in 2009 in the district. As the overall health of the community has improved and education services bolstered, the burden of the overwhelming number of overseas has lessened, and more children are being cared for in their communities instead of caring for their families.